Hello, one and all. Welcome to Pharma Zone. I'm Dr. Sirisha, MBBS MD. Today's topic of discussion is RAAS inhibitors. What do I mean by RAAS? Renin, angiotensin, aldosterone system inhibitors. And this is a quite important topic for both pharmacology people as well as people preparing for NEET or next, as well as people who are writing their general medicine exams. Here we can see an infographic showing how high blood pressure is affecting your kidney, and this infographic helps us in understanding what are the normal values of blood pressure. Before going into the topic proper, by the end of this session, the student must be able to understand the physiology of RAS as well as its pharmacological implications. This presentation will also help you to understand the drugs acting on RAS, will give you a detailed note on pharmacology of AC inhibitors, that is angiotensin convertase enzyme inhibitors, as well as angiotensin receptor blockers. The presentation will help you in understanding the rationale of using these drugs in various cardiovascular conditions, and from now on we start adding a case study as well as certain practice MCQs in every session. So let us start with a small case study. A 65-year-old male is diagnosed with CHF, that is congestive heart failure. He, on examination, was seen with pitting edema, dyspnea, cough, pulmonary congestion, and cardiac dilatation. The vitals are pulse was 100 per minute, respiratory rate of 20 per minute, BP is 130 by 86. You, being the treating physician, prescribed furosemide 40 milligrams once daily and captopril 25 milligrams twice daily. The patient, after 2 hours of taking medicine, under the influence of furosemide, started passing increased quantity of urine, and in the next few hours he started developing weakness, nausea, sweating, and even fainted while walking to the toilet. The vitals at that point of time was BP was quite low, 80 by 40 millimeters of mercury. So what actually happened? Before discussing about the topic and the case study, first we'll understand the renin-angiotensin aldosterone system physiology. The whole story starts in liver. Liver produces angiotensinogen. This gets converted into angiotensin 1. For this conversion, we need renin. This renin is usually secreted by kidney. Whenever there is a decrease in renal perfusion, the juxtaglomerular apparatus will will increase the release of renin, which helps in conversion of angiotensinogen to angiotensin 1. This angiotensin 1 will convert into angiotensin 2 under the influence of the enzyme angiotensin convertase enzyme. This ACE is usually secreted by lungs, that is the pulmonary endothelium as well as the renal endothelium. This angiotensin convertase enzyme plays a major role in converting angiotensin 1 to angiotensin 2. This angiotensin 2 acts on multiple receptors. The major receptors are AT1 and AT2. AT1 plays an important pharmacological role as well as physiological role. AT1 is majorly responsible for increasing the sympathetic activity, as well as it causes tubular reabsorption of sodium chloride and helps in potassium excretion. Because of reabsorption of sodium occurs, water retention also occurs. Along with this, this angiotensin 2 acts on the adrenal cortex and stimulates the secretion of aldosterone. This aldosterone majorly does the role of water retention. Along with all these things, angiotensin 1 receptors, which are present in the blood vessels, are majorly responsible for severe vasoconstriction. Because of this, there will be increase in the blood pressure. Along with this, indirectly, this angiotensin 2 also plays a role in promoting the release of antidiuretic hormone secretion, and water excretion will be inhibited. Because of all these activities, being it increase in the sympathetic activity or being it sodium water retention or water retention, increase in the aldosterone secretion causing increased vasoconstriction or reduced water excretion. With all these effects, basically the circulating volume increases. Because of the increase in the circulating volume, perfusion to the juxtaglomerular apparatus of the kidney will increase, because of which renin secretion will be inhibited. So once our major criteria of maintaining circular volume happens, renin secretion will be reflexly inhibited. This is called as negative feedback. Okay, along with this, this ACE is structurally similar to kininase. This kininase is an enzyme which is very important in metabolizing bradykinin, substance P, and also certain prostaglandins. The same in an easier way, telling us angiotensinogen gets converted into angiotensin 1, which gets converted into angiotensin 2, which is pharmacologically important as well as physiologically important, which gets degraded into angiotensin 3 and angiotensin 4. This degradation is under the influence of aminopeptidase as well as angiotensinase. The active conversion of angiotensinogen to angiotensin 1 is through renin, which we have already spoke about, and angiotensin 1 to angiotensin 2 is through angiotensin convertase enzyme, or because of its structural similarity to kininase, it is also called as kininase 2. So here let us talk about drugs which modulate RAS. What do I mean by drugs modulating RAS? Mainly includes sympathetic blockers, which majorly includes beta blockers, as well as direct renin inhibitors. The best example is aliskiren. This direct renin inhibitors mainly block renin action. They have no role in renin secretion. They just inhibit renin action. So the conversion of angiotensinogen to angiotensin 1 will be inhibited. Next, coming to ACE inhibitors, angiotensin convertase enzyme inhibitors. The best example is captopril, followed by angiotensin receptor blockers. The best example is losartan. And then aldosterone antagonists like spironolactone. These five groups of drugs act on renin angiotensin aldosterone system. Now coming to the first group, that is angiotensin converting enzyme. This as such is a 5 marks question for a pharmacology undergraduate. Drugs acting on RAS is itself a essay. Now let us first talk about ACE inhibitors. Whenever a question comes for ACE inhibitors in your exam, it is always good to write examples like captopril and then start with mechanism of action. Always the mechanism of action, whatever you write, it's always good to write in a flow chart. So angiotensinogen converts into angiotensin 1, gets converted into angiotensin 2 under the influence of the enzyme angiotensin convertase. This angiotensin convertase enzyme is inhibited by ACE inhibitors. This is what happens because of the ACE inhibition, angiotensin 2 formation is inhibited. So, indirectly, aldosterone formation is also inhibited. Because of this inhibition, vasoconstriction does not occur, as well as salt and water retention under the influence of aldosterone does not occur. This aldosterone also plays a role in cardiac remodeling, that is also inhibited. So, what are all the pharmacological actions? Simple, we can happily derive these from our mechanism of action. So, basically, they inhibit ACE. So, angiotensin 2 is not formed. Because they inhibit ACE, bradykinin degradation is not there, as well as because of the no formation of angiotensin 2, there will be significant vasodilatation resulting in increased blood flow to the vital organs. Along with all these, it also reduces aldosterone production. Now, coming to the after pharmacological actions, while writing a short note, it is your duty to write adverse effects. What are the significant adverse effects? It comes with the mnemonic of captopril. C stands for cough. This cough is primarily because of inhibition of bradykinin metabolism. In the same way, angioedema is also because of inhibition of bradykinin and substance P metabolism. Along with this, These drugs are also known to cause proteinuria. Indirectly, this will help us in using ACE inhibitors in diabetic nephropathy. These drugs are also known to cause dysgeusia or taste alterations. These drugs are teratogenic in nature. For that reason, they are completely contraindicated in pregnancy. In the same way, in the case study, we have seen the patient immediately after few hours of taking captopril developed hypotension, that is called as severe hypotension and a first dose phenomenon. How do you overcome this? Mainly by using longer acting drugs, then followed by neutropenia, rashes, itching, loss of appetite, and the most importantly, hyperkalemia. Because of its ability to cause hyperkalemia, this ACE inhibitors are contraindicated in renal insufficiency, as well as they should not be given in combination with potassium sparing diuretics. Now, what are all the advantages of AC inhibitors when compared to other antihypertensives? The alpha blockers, which are notorious to cause postural hypertension, is absent in this. AC inhibitors can be confidently used in these patients, as well as these drugs, they do not exacerbate asthma, as well as they do not cause hyperglycemic unawareness. And these drugs are usually used in combination with diuretics which cause potassium loss. So the hyperkalemia caused due to AC inhibitors is counteracted by the diuretics. In the same way, because of its action mediated through aldosterone as well as inhibition of itself of angiotensin 2 action, it reverses left ventricular hypertrophy as well as inhibits cardiac remodeling. For this reason, these drugs are used these days in congestive heart failure and derangement of lipids, which is most common with beta blockers, is not seen with this. Rebound hypertension, which is seen with central sympatholytics, is not seen in this, and there are no effects on sexual functions. These all are considered as advantages. Now, coming to the next group of angiotensin receptor blockers, the major drugs include losartan. These, the angiotensin 2, which is released, majorly acts on angiotensin receptors. These are either AT1 receptors, which are more important physiologically. There are many other angiotensin receptors, primarily AT2. Here, we are more bothered about AT1 receptor. AT1 receptor is blocked by angiotensin receptor blockers. Because of this blockade, the same pharmacological actions are seen, but the mechanism is completely different when compared to ACE inhibitors. ACE inhibitors mainly act at this level and inhibit angiotensin 1 to angiotensin 2 conversion, whereas ARBs act at the receptor level and block the receptor. These drugs, they have similar effects, similar actions, similar uses, but the major advantage is because of non meddling with ACE, these drugs do not have the ability to inhibit the metabolism of bradykinin and prostaglandins and substance P. Because of this, these drugs have less tendency to cause cough. So what are the advantages of ARBs? Majorly, there is no increase in bradykinin, so very less tendency to develop dry cough and angioedema. And they result in more complete inhibition of AT1. So alternate pathways of angiotensin 2 receptor, angiotensin 2 is there, then also AT1 receptor is blocked, so action is completely stopped. So now coming to the uses, obviously the first line uses hypertension, and majorly in hypertension with diabetes, because of its ability to cause proteinuria, these drugs are known to postpone diabetic nephropathy. Because of this, these are considered as first drug of choice in hypertension with diabetes. And also in patients who are suffering from left ventricular hypertrophy and hypertension, these drugs are drug of choice mainly because they inhibit cardiac remodeling. In congestive cardiac failure also, in the acute as well as in chronic phases, these drugs are used mainly to stop cardiac remodeling and further aggravating the disease. In myocardial infarction, on chronic conditions, while discharging, they usually prescribe the patient on ARBs or ACE inhibitors. In diabetic nephropathy, because of their tendency to reduce proteinuria, these drugs are used. In the same way, these are used in sclerodermal renal crisis and also in prophylaxis for high cardiovascular risk cases. So now let us start with the multiple choice questions. As discussed earlier, from now on, from every session, we'll add a few MCQs. Here I have given you a flow chart. So now tell me what are the drugs which helps in inhibiting conversion of angiotensinogen to angiotensin 1. So the group of drugs which act here are direct renin inhibitors. So now coming to the next drug, that is Y, which mainly acts by inhibiting angiotensin 1 to angiotensin 2. So what is the drug which is acting here? They are ACE inhibitors. Now coming to the Z, which is mainly acts by blocking AT1 receptors. These are ARBs, angiotensin receptor blockers. Now coming to the second MCQ, which statements in this are true? Now tell me, what is aliskiren? Aliskiren is a direct renin inhibitor. Does it act by inhibiting the secretion of renin? No, it acts by inhibiting the action of renin. It has no role in secretion. What is enalapril? Enalapril is a ACE inhibitor and they are notorious to cause cough and angioedema. Yes, losartan inhibits the formation of angiotensin 2. Do you think this is correct? No. Losartan is an ARB and it blocks AT receptors, AT1 receptor. Okay. Eplerenone causes gynecomastia. Do you think? No. Eplerenone and spironolactone are basically a aldosterone antagonist of all. Spironolactone only causes gynecomastia. Eplerenone is a recent addition to the group and is not known to cause gynecomastia. And then a newer drug here, that is somapatrilat. Omapatrilat and sampatrilat are the two drugs where they are basically vasopeptidase inhibitors. That is, they have inhibitory action of neprilysin. What are the vasopeptide enzymes you know? One is neprilysin, the other one is ACE. So, somapatrilat has action on neprilysin as well as ACE. So, the correct statements are B and E. Now, the third MCQ, where a 52-year-old was treated with enalapril for hypertension and he is able to convert his blood pressure. Now, you tell me what is enalapril? It is an ACE inhibitor. So, when a patient is on ACE inhibitor, conversion of angiotensin 1 to angiotensin 2 will be inhibited. So, obviously, angiotensin 1 levels should be high. Because of angiotensin 1 levels being high, its precursor of renin secretion will also be high. So, renin and angiotensin 1 levels will be high, whereas angiotensin 2 levels will be low. Aldosterone secretion is majorly mediated through angiotensin 2 action. So, aldosterone secretion will also be low and bradykinin, which is usually metabolized by kininase, metabolism is also inhibited. So, bradykinin levels are also high. So, renin is high, angiotensin 1 is high, angiotensin 2 is low, aldosterone is low and bradykinin is high. So tell me what is this picture? It's a angioedema mainly because of captopril. Now tell me what is this MRA, magnetic resonance angiography of renal blood vessels showing you? It is showing you typical bilateral renal artery stenosis here. Yes. So in these conditions AC inhibitors as well as ARBs are contraindicated. Now coming to the next MCQ, these I have focused on whatever I have not covered previously I am covering in MCQ. So it is good to focus on everything. Now tell me what is telmisartan? It is an ARB, angiotensin receptor blocker. This telmisartan has an additional PPAR gamma agonist. Because of this, this can help in treating dysglycemia. For that reason only, telmisartan is nowadays being increasingly prescribed whenever a hypertensive with diabetes is being coming to our OPs. And then losartan. Losartan is a angiotensin receptor blocker. It has an additional property of competitive thromboxane A2 antagonism. So it has an effect of antiplatelet effect. In the same way, enalapril is a prodrug of all the ACE inhibitors except for captopril and lisinopril. The remaining all are prodrugs. Now tell me, captopril is used in congestive heart failure. Is the assertion true? In the same way, ACE inhibitors reduces aldosterone mediated cardiac remodeling. Is it true? Yes. Assertion is true, reason is true, and because of its ability to inhibit cardiac remodeling only, we use ACE inhibitors in congestive heart failure. So, assertion is true, and reason is able to explain assertion. So with this, I want to conclude. And if you have any queries, please do mail to doctor.farmazone@gmail.com. Thank you for your patient listening.